Well, hi, everyone. Thank you so much for having me here today. I'm sorry I can't be there in person, but I am thrilled to be here to talk to you about NHATs. Some of you may be familiar with NHATs, but for those of you who aren't, I'm hopefully going to give you a nice picture today about how NHATs can be used to address aging-related questions, especially those related to health disparities, as well as Alzheimer's disease-related questions. So NHATs has been in existence since 2011. That's when data collection was initiated. It is a cooperative agreement with the National Institute on Aging. And it was initiated by Judy Casper and Vicki Friedman. Vicki's at the University of Michigan, as a platform for scientific inquiry to guide efforts to reduce disability, maximize functioning, and enhance quality of life in older adults. I should note that I took over for Judy as PI about a year and a half ago, so I am relatively new to it. The study design that we use is designed to support the study of disability trends and dynamics in older people. And we get broad multidisciplinary input from the scientific community through multiple mechanisms, and I'll show you later all the different experts that we approach to get input to see that we're really trying to get at all aspects of aging as much as we can in the field. And then dissemination of what we collect is a key component of NHATs, and that's really what I want to talk about today. So some of our key features is that we are an annual in-person panel study, and we have periodic replenishment. So the study was initiated in 2011, like I said earlier. It was replenished in 2015. We were supposed to replenish again in 2020, but of course, because of COVID, that was put on the back burner. We started replenishing this past year in 2022 and are continuing it in 2023. And I'll show in just a few slides what that means in terms of sample size. We do oversample older adults over the age of 90 plus, Black older adults, and Hispanic older individuals, because these people are really historically underrepresented in scientific research, as everyone who is in this room and on this call likely knows. Our content is guided by a conceptual framework for late life disablement and its components. And we really try to look at people's capacity, the environment in which they live, and compensatory strategies and accommodations that they use. And I'll show you that conceptual framework on the next slide. We release our data annually, and our goal is to release high quality, user-friendly, and well-documented data files. So it's easy for people to access, easy for people to understand, and hopefully easy to use. This is a conceptual framework that I referenced earlier. So as you can see, we take into account the environment in which people live. Do they live at home? Do they live in a facility? Do they live with people? Do they live alone? We think about health conditions. We think about their impairments in body functions and structures, and also their capacity for mobility, both upper and lower body, their sensory function, as well as their cognitive function. And then if they need them, do they have the accommodations? Are they getting what they need? Do they have unmet needs? And we assess this by looking at their ability to carry out essential self-care and domestic daily activities. So we look at participation and productive, generative, and community, social, and civic life. We try to really get at all of these things with an extensive interview. So as I mentioned earlier, I'm the PI at Johns Hopkins, and Vicki Friedman is the PI at University of Michigan. We do our annual field data collection through Westat. We deploy over 100, anywhere between 100 and 200 interviewers in the field annually. It depends on our sample size that year. And we get our input, as I mentioned earlier, from an interdisciplinary investigative team. And we have multiple advisory groups. We have a steering committee and a data monitoring committee that provides feedback multiple times throughout the year. Our experts that we reach out to include people from public health, epidemiology, demography, sociology, health policy and public policy, health economics, geriatrics, and physical medicine and rehabilitation to really try to get at this comprehensive picture of what life is like for older adults. So a little bit about our sample design and data collection. So our study population is drawn from Medicare beneficiaries age 65 and older. So our sampling frame is the CMS Medicare enrollment file. Our sample design is age stratified in 5-year age groups. And again, as I mentioned earlier, we oversample those over the age of 90, as well as Black and Hispanic persons. We are a panel study with annual in-person interviews. As I mentioned earlier, we go to people's homes or we go to the facilities in which they live to do the interview. Round 1 was in 2011. And again, as I mentioned earlier, we do periodic replenishment, which I really have outlined here on this slide. So if you can see this, the blue bars are the original cohort that was started in 2011. And as you can see, we've had people die throughout the years and some attrition. And then we did a replenishment in 2015. That's what the green bar is. So the green is our second cohort that was added in that year. And then you see here in the purple what we've added so far in the current replenishment cycle. So right now we are somewhere around 6,000, just over 6,000 older adults. And we hope to be up to closer to 10,000 by the end of 2023. We have excellent response rates from those who participate and continue to be eligible to participate. So you can see of those enrolled and eligible of the continuing cohort, we generally are in response rate in the 90s year over year. The years that we dip below that tend to be replenishment years. So round 1, that's the overall response rate was around 71%. And then year 5, again, with replenishment, about 77%. We have a double star next to round 10 because that was 2020, and that was done phone only because of COVID concerns, of course. So then you see our response rates broken out by those who are alive and eligible. And then we do have people die in between rounds, and we do our best to get what we call the LML, or last month of life interview, with their next of kin. Or the person with whom they reported living, to try to get an idea about what their last month of life was truly like. This is our sample breakdown by race and ethnicity. So this is where we were in round 12. And one secret with NHATS is that the last digit of the round number corresponds with the year number. So round 12 was 2022. Round 13 is 2023, and this is what our target's going to be. So currently we're about 69% white, 22% Black, non-Hispanic, and just under 13% Hispanic. So we did get some extra funds to try to augment our Hispanic sample. And so around 13, we hope to really increase that to be closer to 20% in Hispanic and Black. That will come down a little bit as a result of just the increase in the overall sample size. And then white, non-Hispanic to be around 61% is what we're looking for by the end of round 13. So what do we do when we're with people? What do we ask them about? We have what's called the SP interview. That's the sample person interview. And this is completed with a participant. For most of our participants, about 93%. We do have some proxy respondents, so that's somewhere around 7% usually. And this is an extensive interview that takes about an hour on average. It depends on the person's physical state. And then we also do physical performance testing, cognitive testing, we do hearing and vision testing, we do a cog state assessment on the tablet, and then we have accelerometry and a subset. And this adds about another 30 to 60 minutes, again, depending on the person's physical state. So altogether, we're generally in the home about 2.5 hours. That can go as long as 3 hours if we have somebody who really needs to take their time. For participants who live in residential care, we do what's called an FQ, or a facility questionnaire. This is completed with a staff person, and we try to get information on the level of care that the facility provides, the services that are available, and also the cost of care. And then, as I mentioned earlier, for participants who die between rounds, we try to get what we call the LML, or last month of life interview, and this is conducted with a proxy respondent. And we have this was started in round 2. Late life of disability is our main goal, to understand trends and trajectories in disability. NHATS is unique in that we really try to distinguish accommodations from limitations. So we measure participation beyond basic self-care and household activities, and we try to get more fully into measures of the physical, social, technological, and service environments to understand what people are really able to do as they age. We typically ask people about their ability to do things in the past month. So we use a 1-month time frame. We do not ask them about hypothetical situations, such as how hard would it be for you to do X, because we worry about people's capacity to understand and answer those questions. And then we refer to accommodations by name. We don't say special accommodations. We just say, do you have accommodations for mobility? Do you have accommodations for a sensory deficit like hearing, to use hearing aids, things like that? We don't call them special accommodations. This is a list of our core assessments. There's a lot here because we are pretty thorough, or try to be pretty thorough. I'm going to go through these on the next couple slides and break these down a bit. And these, again, are all on our website. We have a really extensive website with all of this information where you can get the whole instrument if you want. It's several hundred pages where you can see what we ask and how we ask it. But we do, again, ask about aspects of daily life. We ask about helpers in their environment. We ask about their functional abilities. And of course, we ask about cognitive abilities, and we assess cognitive abilities. And we look at race, ethnicity, and language, which are especially relevant to the topics we're talking about today. So in a little bit more detail to touch on some of these measures. So we ask about self-care and mobility, people's ability to dress themselves, to eat, bathe, and use the toilet. We ask about if they're able to go outside and if they're able to get around inside their home. We ask about ability to get out of bed. We ask about how their activities are carried out, whether they use devices and the level of difficulty, both with and without the device. And then we ask if they get help. And that's a unique aspect of NHATS, is this focus on help and caregiving, which I'll talk a little bit more about towards the end. We also ask about household and medical activities. So are they able to complete their household activities? And if not, do they get help? So things like laundry, preparing hot meals, taking medication, bills, and doing banking. And if they need help, why they think they need help, or why they need help, and how often they do get that help to do these things. We ask about medical appointments, getting to the doctor, and whether someone sits in on the visit with them. We ask about how activities are carried out. So this is getting at what I was just saying earlier. Do they do it by themselves or with someone's help? Or does somebody do it for them? Or maybe it varies on the person's availability. We often asked about how often they do these tasks, and whether they have difficulty when they're by themselves. And we also ask about the technological environment, since this is so relevant, especially now more than ever before, about people's ability to get online and conduct things online if they need to. We ask about physical capacity. So in the last month, were you able to do something like walk 6 blocks by yourself? So this would be about a half a mile for most people. It depends on the size of the block. And then we ask about if they did it by themselves, or did they do it with a cane or a walker? If they say no, if they refuse or don't know, then we get to an easier activity. An example here would be walking 3 blocks if they said they couldn't do 6 blocks, to try to get this idea of their physical capacity. So in addition to asking about their ability to walk these distances, we do a similar pattern with asking them about walking upstairs, 20 stairs or 10 stairs, lifting and carrying 20 pounds or 10 pounds, kneeling, bending over, putting a heavy book on a shelf, reaching up over their head and opening a sealed jar, using their fingers to grasp objects. And then also things like balance, chair stands, and gait speed, which are traditionally part of the short physical performance battery, and then grip strength, peak airflow, and accelerometry. So I guess I should clarify, I'm sorry, back up a little bit, that these are all performance-based. So the ones I mentioned before on the previous slide were physical capacity self-reported. These are physical capacity, the actual performance based. So we do the traditional balance stands of side-by-side, semi-tandem, and full tandem. We do 5 chair stands done as quickly as possible. We do gait speed over 3 meters. We do grip strength. Peak airflow is similar to a pulmonary function test, except we don't have a full spirometer in the home. It's a smaller handheld device that measures peak airflow. This kind of gets at their cardiorespiratory capacity. And then accelerometry was measured in a subset. We originally flagged about 1,000 people to try to sample this in to see how it would be received. It was scheduled again for 2020, but delayed to 2021. So by the time we got to everybody, and then actually had people wear them, and then we got usable data on about 750 people, which is actually close to about 88% of those who were eligible to participate in that. Cognitive measures. So we have a lot of cognitive measures in NHATS. We have self-report of a diagnosis of dementia or Alzheimer's disease from the participant. If they have a proxy, we do the 88 to get at screening of memory, orientation, judgment, and so on. And then we also have a battery of cognitive assessments for those who are able to complete them. And I'll go through those on the next slide. And then we added some tablet-based activities in 2021. So we assess memory, as I mentioned, by self-report. We ask them at the present time, are you experiencing memory problems? Do these interfere with your daily activities? We ask about their memory compared to 1 year ago. And then performance-based, we do a 10-word recall. We do immediate and delayed. Orientation, we ask about the day of the week, month, day, and year. We ask them to name the president and vice president. We do a clock drawing test, and we're working on the mental alternation test, also known as the MAT. We had some trouble implementing this in the field in 2021, so we're working through the 2022 data. We had some interviewer errors where the interviewers forgot to start the clock, which is a key part of this test for those of you who are familiar with it. For those of you who are not, it's alternating letters and numbers and asking people to go back and forth and list them, and timing is a key component. So although we started this in 2021, we found enough errors in the data that we weren't comfortable releasing it. We're hoping we'll be able to release the 2022 data, though, with the MAT. And then we also have the COG state, which is a computerized cognitive battery that's done on the iPad, which I have a screenshot of here on the next slide. So this is a digital iPad-based assessment of cognitive function, and this is a screenshot of what the iPad screen looks like for those people who may not be familiar with it. There are 3 parts to it. The first is a detection test where we ask, has the card turned over? And the participant hits yes or no. So do you see the face of the card, yes or no, as it turned over? There's an identification test where we ask, is the card red? And that answer yes or no. And then there's what we call one card back, where we have a certain card and then we flip to another card and we say, is this it's the same as the previous card? So this gets at working memory. And this is a pretty new test for us, so we're excited to see how the data looks from this. We also do clock drawing. Participants are given a blank piece of paper and an erasable pen and instructed to draw the clock with all 12 numbers and all the hands showing at 11:10, and they are scored using a 0 to 5 scale. So I'm sure many people in the room are familiar with this, but just in case you're not, this is what a typical clock looks like from our participants. So you see a clock with numbers, and of course the hands are drawn to 10 minutes after 11. And we have quite a few of our participants who also give us impaired clocks. And I will tell you that I think NHATS may have the largest store of clocks anywhere. We keep them on our Michigan Data Enclave. There are probably over 25,000 clocks on there. So for people who are interested in using clock drawing tests as for all sorts of reasons, both predictors and outcomes, we have quite a large stash of them. So you should definitely look at our website about this. We take all of this information and we do have, this is really kind of nicely set up by Melinda in her presentation earlier. We have this probable dementia classification, and it's based on these criteria. So if the participant reports that a doctor told them that he or she had dementia or Alzheimer's disease, then we classify them as probable dementia. We also look at the 88 if the participant has a proxy, and if they have a score of 2 or higher on the 88, we classify them as probable dementia. And then if based on their testing scores, if they have a score greater than or equal to 1.5 standard deviations below the mean in 2 of the 3 domains of memory, orientation, and executive function, we classify them as probable. If they are only in 1 domain, we flag them as possible dementia. So if you're familiar with NHATS, we have both possible and probable dementia. And this algorithm has been validated with the HRS atoms. It has 72% sensitivity for probable or possible and 84% specificity. And we are right now looking at co-calibrating this with HRS HCAP. Other key components and modules that NHATS has done through the years, we did dried blood spots in round 7. We got some inflammatory markers and we got CMV. We are working with NIAGADS to upload some of the genetics data to that site for those of you who are interested in genetics. We did a 1940 census match with round 5, where there was linking information between the round 5 collection and the 1940 census. And then we also have the National Study of Caregiving, which I mentioned briefly earlier. This is a complementary study to NHATS. It's known as NSOC. And what it is it's an R01, so it's separate from NHATS for now. Going forward, we're looking at merging the two studies together. But we give periodic interviews to families and unpaid caregivers of NHATS participants. So what this does is this gives us information on family and unpaid caregivers' perspectives to help us get a well-defined sample of older adults who are receiving care. And this is really important for people who are interested in studying Alzheimer's disease and dementias to understand how these people are being cared for and how they're receiving the care and if they have unmet needs. We conduct interviews with up to 5 family or unpaid caregivers, and that's important to stress unpaid caregivers. If they report paid caregiving, a company or a paid nursing help that comes in to help them with daily tasks, we do not interview them. This is strictly family or unpaid caregivers at this time. Most of these interviews are completed within 4 weeks of the actual NHATS interview. So when they have their interview, if they report receiving care or receiving help, that's when we flag them and then try to get in touch with their caregivers to conduct the interviewers. The content focuses on the caregiver's situation and their experience. And then this gives us the unique linked perspective of the older adult and their caregiver to truly try to understand this continuum of disability and care. So some of the content areas specific to NSOC include care activities, what do they do for the participants, the intensity and duration of care, both the positive and the negative aspects of caregiving, things like services and support in their environment, distance, how far do they live from the participant in terms of that they're providing care for, participation in activities. And then we also ask about caregiver health and well-being. We're interested in household composition and demographics. We're interested in caregiving and employment. Are those who are providing care able to remain employed? We look at insurance, income, other person's costs and transfers, things that come as a result of caregiving. If they were providing care and then stopped, the reasons it was stopped, maybe the participant didn't need it anymore, maybe they transferred into a facility. And then, of course, as I mentioned earlier, maybe the last month of life interview if the participant dies. And we try to look at healthcare interactions if they help people with their care, if they take them to doctor visits, those kinds of things, and then a time diary. Some other periodic modules that NHATS has had through the years include National Long-Term Care Survey screening questions in round 1 and round 5. And then there have been some external investigator-initiated modules. So the ACS disability items, there was a module on end-of-life planning. So these are modules, I should say, that we don't have every year, but they do exist, and they are in the different years from round 1 up through round 12. Healthcare preference and engagement, sleep quality, pain, personality, medication attitudes, preferences and living environment, and then there was a sedentary behavior module as well. So we have data on all of these things. Usually it's not in the full sample, usually it's in a subset of the sample. So data dissemination, what is out there, what's available, and how do people access it? So in general, our goal is timely release of high quality, user-friendly, well-documented data files. And these are all on our website, which is nhats.org. When you go to nhats.org, there's 2 sites. There's the researcher and the participant. You want the researcher side. You can look at the participant side, but it's not going to give you what you want. And then there are different levels of access. We have publicly available data that you just have to register for. And the only reason you have to register is because we like to know how many people are actually using our website and using our data. So we do ask people to register because it helps keep the study going. And then we have sensitive files that you have to fill out some more information on. And then we have restricted files. And we have two enclaves. We have what we call the MICTA enclave, the Michigan Center for the Demography of Aging enclave. And then we have the HAID enclave, the Health and Aging Data enclave. And I'm going to talk a little bit more about what those are on the next slide. So our public files include data from rounds 1 through 11. So as I said, round 12 was just completed this summer. We usually will release the beta version of the previous round the following summer. So it takes us about a year to get everything cleaned, processed, and ready to go. So like, for instance, 2022 files will probably be available in maybe July or August of this year. That'll be the beta version, and then the final version usually comes in the fall. We have our sensitive files, and then we have that include rounds 1 through 11. And sensitive files include more demographic information. So they have things like age in terms of the exact year. So if you were to download our public files, it would just have year of age and 5-year age groups. The sensitive files have year of age. It has things like veteran status and so on that we just consider a little bit more sensitive because they're a little bit more identifiable. We have dried blood spot assays and information on those. And then we have NSOCs round 1, 5, and 7, both cross-sectional and longitudinal. Then we have our restricted files, the Medicare claims. So this is a new partnership with Medrick. So anyone who's ever done Medicare linked analyses knows this was quite a process. You had to apply to CMS, you had to get the data, you had to pay for the data. Right now, there is no charge to do this, which is exciting, and we hope it remains that way. So you can apply to us, to Johns Hopkins, to NHATS to do this, and then you apply to NIA. And so you have 2 data use agreements, one with Hopkins and then one with the NIA. And if both are approved, then you are admitted into this enclave, and you can do your analyses in there, looking at all sorts of health outcomes with Medicare claims data. There are geocoded sample person and other person files on the MICTA enclave. So if you're interested in geography, we have it currently at the census tract level. We are working on getting block group together and hope to have that available in the MICTA enclave, perhaps as soon as this summer. Also in the MICTA enclave, we right now have the HRR file. That's the hospital referral region file. So you can go in and link our data with hospital referral region. So right now we have over 6,000 registered users on our website. So a lot of people are using our data, and that's really exciting. We love to see that. We have a lot of registered users for the sensitive files, and the restricted files are coming along as well. This is really gaining in popularity, and we expect it to only get bigger, especially now that there's not a cost associated with it. We have a lot of users, just to give you an idea of who uses our data. So all those things I mentioned earlier, in terms of the expertise that we ask about, it seems to pay off, because we have the most common disciplines of people that use them are health services, gerontology, epidemiology, public health and public policy, psychology, statistics, economics, geriatrics, sociology, and demography. So we appeal to a lot of different users. We have a lot of publications. So if you look at our publications by year, this was updated as of the end of 2022, our estimated number as of the end of 2022. We have our publication list is really just growing. And we have a lot of grants that are using NHATS. To date, we have 63 NIH grants, 51 are with the NIA to analyze NHATS and NSOC data. So if you're interested in secondary data analysis, we are a great source for that. There are an additional 7 that involve NHATS and NSOC, so our caregiving complementary study. And more than half of these grants are related to AD and ADRD topics, and about 1/3 are RO1s. There are quite a few career development awards, both KO1s and K99s as well. So with that, I think I'm pretty much close to time, and I wanted to leave time for a few questions if there were any. So these are my acknowledgments. Again, our website, I highly encourage you to visit it. There's a ton of information on there, way more than I could ever have time to go through, but basically everything I presented, but then all the details too, the user guides, technical papers on how different variables were derived and things like that. I want to acknowledge Vicki Friedman, who's my co-PI at Michigan, Maureen Skian, who is our senior research associate at Hopkins, the Westat team, who does our data collection and really helps us run the study. And then, of course, our funding. We're funded, as I mentioned, through a cooperative agreement with NIA. If you're interested in more information, there's my contact information at the bottom. So with that, I will open it up for questions. I don't know if you guys can see me or not if I turn my camera on. There I am. Hi.
There is one question online. Can you comment on the representation sampling of Asians or subgroups of Asians in NHATS?
Yeah, that's a great question. So we actually looked at the plausibility of doing a supplement to enhance enrollment of older Asian adults. And it became very, very complicated. We actually consulted with several experts in the area because of language difficulties. We were able to do a Hispanic oversample because it's fairly easy to find Hispanic speaking interviewers, but it's very, very difficult to accommodate all of the different languages that would be needed to do an Asian oversample. So at this time, it's a pretty small percentage. It's definitely in the single digits. It's probably about 3%.
Thank you.